It's titled Physician Burnout, Changing the EHR from a Liability to an Asset. Very timely. And we've got two great speakers. I had the opportunity to chat with them beforehand just to say hello and be sure I could pronounce their names properly and all those good things. So really seem like really dynamic gentlemen. So we've got Dr. Alan Chaoui, and he is the immediate past president of the Massachusetts Medical Society. Dr. Chaoui is a Boxford resident and primary care physician and president with the Congenial Healthcare LLC. And that's a private practice group with multiple sites on the North Shore. And he's been elected president of the Mass Medical Society at the organization's annual meeting, April 28th at the Seaport Hotel in Boston. He's dedicated to medical education. Dr. Chaoui holds 4 teaching positions, and those are Assistant Clinical Professor, Family Medicine and Public Health at Tufts University School of Medicine, Assistant Clinical Professor of Family Medicine at Boston University School of Medicine, Clinical Adjunct Professor at Boston College School of Nursing, and Clinical Professor in the School of Physician Assistant Studies at Massachusetts College of Pharmacy and Health Sciences. That's a lot. Now we've got Dr. Larry Garber, Medical Director of Informatics, Reliant Medical Group. Dr. Garber is a practicing internist, board-certified clinical informaticist, and medical director for informatics at Reliant Medical Group, which is a 500-provider, multi-specialty group practice. He's chair of the Massachusetts eHealth Collaborative, a board member of Direct Trust, and a prior member of the ONC Policy Committee's Health Information Technology Interoperability Work Group and Interoperability Experience Task Force. He's been principal investigator on the $4 million AHRQ, HHS, ONC, and MIHI grants to develop innovative health information exchanges, HIEs, interoperability, and a proponent of the hassle-free HIE. He's helped update the HL7 consolidated CDA to better support care plans. So very highly qualified. We've got Dr. Chaoui and Dr. Garber talking about changing the EHR from a liability to an asset. So, gentlemen.
Thank you. That's pretty fast, so. Thank you. I am so humbled to be here in front of you today. I usually give this talk to physicians. And today, it's my pleasure, actually, to give it to patients and IT gurus and specialists, because I've been wanting to talk to you for a long, long time. And thank you for being here. So I would like to start by saying that we learned a lot from Dr. Parker, that data is important, and taking care of patients is important, and paying attention to patients is important. So hold that thought, because this is where I'm going today. So I wanted to thank New England HIMSS for having us here today, and I wanted to say that as a practicing family physician, all I've been wanting to do is to make sure that we deliver the highest quality care for our patients and preserve the patient-physician relationship. Here it is. Thank you. So today's topic is physician burnout, and I want to tell you what are some of the drivers and how is changing the EHR from a liability to an asset. Right now, the EHR feels like physicians are slaves to the EHR, and we would like the EHR to work for us and for the patients. So, so what is physician burnout? Burnout in general is emotional exhaustion, depersonalization, and low sense of personal accomplishment. And you can have one or the 3, or it's even more than those 3, but this is how it starts. It's that bad that we don't call it physician burnout as much, we call it moral injury. So Simon Talbot actually said, you know, it's kind of shaming the victim to call it a a physician burnout. It's actually moral injury. And he went on to say that it's the results of having the physicians deal with things that have nothing to do with patient care. So physicians never complained about taking care of patients. Physicians love to take care of patients. I went to med school to take care of patients. And then I find myself having to deal with something that has nothing to do with patient care, and that takes me away from patients. So when I went to med school, I saw that this is how I perceived doctors, at the bedside of the patients, taking care of patients, listening to patients, holding hands with the patients that need care. Now doctors are perceived as this. Who sees their doctors on the computer all the time? So that's what a lot of patients are complaining about. At one point, patients are saying to the doctors, "Can you please look at me?" So is modern medicine upholding its promise to our patients? So that reminded me of an episode of I Love Lucy. Everyone in the room here remembers I Love Lucy, the episode of Lucy and the Chocolate Factory. So Lucy and Ethel are doing the job that everyone loves. Who does not love chocolate? Same thing. Which doctor does not love to take care of patients? And then you have those chocolates going on the conveyor belts. Everything is happy until the conveyor belt is faster and faster. They're putting chocolate in their mouth, in their hats, in their pockets. And the boss comes out and says, "Wow, they're doing a good job. Speed it up, speed it up." Does it remind you of something? Yeah, a lot of physicians says that's how our life feels. I feel like I'm always behind. I'm always trying to catch up. A lot of doctors and clinicians say, "We're up after the kids are in bed. You know, if dinner is ready, now it's time to sit on your laptop and do patient's chart until midnight." So what is the impact of burnout? Who does it affect? A doctor by the name of Tate Chanafeld from the Mayo Clinic, who we had the pleasure of having as a speaker in our annual meeting last week, he has done extensive studies, and it affects both the personal life and the professional life. Broken relationships and alcohol and substance abuse, depression, and even suicide. We lose about 400 physicians per year. That's 4 medical school classes per year. And in terms of the professional impact is people feel that there is more medical errors because you're not paying attention, and there is likelihood of medical errors. Patients are less satisfied, and physicians are turning over. So it's a big problem. A lot of patients says, "Where is my doctor? My doctor keeps moving, and I can't keep track of my doctors." What happens to the physician that you've had for 25 years and 30 years? And doctors are leaving the practice as soon as they can. They're retiring early, and they are going into cutting their hours and trying to move into something that's not medicine, and that's sad because that's not why they went into med school. So 1 out of 2 physicians experience symptom of burnout. Sometimes they say 70% of doctors have at least one symptom. It is more common, more likely than the general population, and it affects all specialties. And we compete every year. We have sometimes the ICU, internal medicine, family medicine. Next year will be ER medicine. So it affects all specialties. So how did we get there? Well, we had good intentions. At the beginning, we said, okay, the paper chart, maybe you're not keeping the data. Remember when I said, Dr. Parker said the data is important. I am one of the first physicians on the North Shore that wanted to have AMR, because I believe that you keep your data, you do a really good job, to serve the patient. It's a tool to actually help take care of my patients. So in 1999, we had the Institute of Medicine to Err is Human, and they drew the attention to medical errors. And we said we need to figure out ways to protect the patients. Patient safety is very important to doctors. And then the American Reinvestment and Recovery Act mandated the meaningful use in EHRs, and I said, okay, well, it's important that every one of us, so we can talk to each other, so we can be interoperable and communicate with each other. The Affordable Care Act, and then everyone started to pile it on. Regulatory, documentation, quality measurements, prior authorizations, and this is how we got into this. So from becoming a tool that is very helpful in the care of patients, it's becoming a burdensome tool that actually takes your attention away. So the drivers of burnout are multiple. But for the sake of today, I wanted to talk about the EHRs, because EHR was especially created for billing purposes and not for patients' care. But I believe in my heart that fixing the EHRs at this point in time is very, very important. It's urgent. So some of the factors of burnout is lack of leadership, having a prior authorization. We spent about 45 minutes on the phone to try and get an okay to do a CAT scan or an MRI. Wouldn't you prefer that I spend those 45 minutes with the patients? The administrative burdens, every insurance companies have a bunch of quality measures, up to 133 quality measures. And we're working to make sure that if we want quality, doctors want to take care of patients, but let those qualities actually be important for patient care, not just checking off boxes. So in the past, we used to say, doctor, you need to be a little bit more resilient, or it's an individual problem. Now we believe it's a systems problem. I liken this to the healthcare to a big ship, and doctors are overboard. And while they're in the water, you say, doctor, I would rather you learn how to swim better, maybe do some yoga, maybe that'll help a little bit, be a little tougher, instead of me, throwing them a life jacket or a rope and bringing them on board and having them, help do their jobs. So what did we do about this? So we gathered a group at the Medical Society. We called it the Task Force on Physician Burnout. And we invited the Mass Hospital Association, the Harvard T.H. Chan of Public Health, and the Harvard Global Health Institute. And we formed a task force with some of the specialists in this field. And we invited, we came up with this paper that that has a few things that are very important. The first thing is the Harvard School of Public Health, after looking at our data, decided that physician burnout is a public health crisis. That means it is not just affecting, it's affecting everyone. Number two, we came up with 6 recommendations of how to actually improve the system and make some of the changes. Some of these recommendations is to support mental health treatment and physician experience. So we noticed that a lot of the physicians are so busy and so burned out that they don't pay attention to their health, or they don't even mention anything about that. And in order for us to be for us to be taking care of the patients, we need to take care of ourselves. The same thing as you're in an airplane. You need to put the oxygen mask on yourself first before you do it for your patients. And, of course, improving the EHR, because now we would like to make the EHRs work for the patients and for the healthcare system, for us, not us work for the EHR. And we would like your help to do that. And then we also wanted to make sure that we have chief wellness officers in all the organizations that actually pay attention to the wellness of the caregivers, because it's important to be healthy in order to deliver health. So improved EHR standards with APIs, and I think Dr. Garber is going to be talking more about this today. And some of the questions we have: is it possible to improve EHRs? Are we ever going to get to a point where, one of my examples is, if anyone ends up in an urgent care here or an emergency room in this town, and then they have their X-ray or CAT scan and labs, and then they go home across, to the North Shore, and they end up in another institution with the same electronic record, would they have access to your information? As a patient, I have a patient that was seen in an emergency room one day, 2 days later in another emergency room. They had to repeat their blood test. They had to repeat their CAT scan. Why is it not interoperable? Why do we have a problem with interoperability? Can you help us get there, please? So we came up with another paper with the help of Dr. Garber and Dr. Defossé from the MHA. And Dr. Garber is going to be talking to us more about how, from our standpoint, we would like to help and how we can help. Dr. Garber.
Perfect. Very good. Thank you. So first, let me tell you about Reliant Medical Group. That's where I've been working for the last 33 years. We're a 500-provider multi-specialty group practice located throughout central Massachusetts in the Worcester County area. And I think what's most important is that we have had, over 40 years, the vast majority of our patients have been in risk-sharing, capitated, value-based care contracts. And that's somewhat unusual, but it's probably because we were the ones that started Fallon Health Plan 42 years ago. And so we've always had a focus on quality and controlling costs. Because of that, we actually implemented our electronic health record we wrote our own back in 1993, long before meaningful use. And as a result of that, we were the first ambulatory-only practice to become recognized as HIMSS Stage 7. Okay, technically we were tied for first place with Atria, so thumbs up to Atria as well. So, and we also were a HIMSS Davies Award winner. So thank you for the HIMSS folks in the room for recognizing that. So let me tell you about what we've done to help reduce physician burnout. And but first of all, I want you to understand the principles that we followed. When we started this back in '93, we weren't thinking about physician burnout. We were thinking about how can we be successful in what we're doing and what we're implementing. And what we've really learned is that for any EHR implementation, for any health information exchange implementation, in fact, any technology implementation, you really have to accomplish 3 pillars of success. You need to get 3 things right. If you don't get all 3 things right, you're going to fail. So number 1, all the stakeholders have to find value in what you're doing. So you're implementing electronic health records. The physicians who are using it have to get value out of it, and they have to recognize that they're getting value out of that. Also, the nurses, the secretaries, everyone who uses it has to get value. The patients who are part of the system integrating into the electronic health record have to see the value in it. And the leadership, the CFO who's signing the checks, needs to see that there's value in this. Second thing, it has to fit into real-world workflows. Healthcare's busy. We're patients are constantly calling, getting sick. There are things that we need to do. It has to be efficient. It has to fit into our workflows. You can't expect us to be going to multiple different websites. For that matter, you can't expect me to go from one screen to another, to another, to another to find all the information. Count the clicks. It all has to be in one screen, so I don't need to scroll. I don't need to click to see all the things that I need. So it has to be efficient. And then lastly, you have to develop trust. And this is really important. A lot of people forget about this. But you need to get, first of all, obviously the trust of the patients, that their data is not going to be stolen and put on the front page of the Boston Globe. But also the physicians and nurses have to trust that you are implementing the best electronic health record that you can, that you're implementing it in the best way that's possible, and that when they identify a problem, you're going to be responsive in fixing that. You're going to listen to them when they have an idea. You're going to implement those ideas if you can. You know, that's the trust that you need to do. Then, of course, the CFO needs to trust that you're going to make back the money that you spent on your electronic health records. So another way to remember this, what I simply call it the 3 U's. It has to be useful, usable, and you have to develop trust. So remember that in everything that you do. So, and that's what we did, is we went through and designed our electronic health record and our health information exchange. And our focus in terms of interoperability was, we want to make sure that whoever's taking care of our patients, they have the information that they need, all the information that they need to do a good job taking care of them. So we've done quite a bit of work on interoperability. On this drawing, this is Reliant in the middle here. And so, for instance, we've got over 50 physicians in the community that do a lot of care for our patients, and so we've given them direct access to our electronic health record system. We also have query access, but where we can query other organizations and they can query us through Care Equality. And that's been superb. I mean, not only are we seeing we have Epic as our electronic health record. Not only do we see other Epic records, but we also can, we're seeing Athena, we're seeing eClinicalWorks, we're seeing NextGen. Commonwealth is just connected to Care Equality, so we expect to be able to see Cerner and other electronic health records as well. And it's very efficient. It shows up right in my electronic health record. I don't really have to go anywhere else to see this stuff. We've also set up a lot of point-to-point interfaces in central Massachusetts. We're connected to 10 hospitals directly, so that when my patients, first of all, when my patients are in the hospital, I get automatically sent to me. We subscribe to our patients' data. I get every single lab result, every single radiology report, procedure note, admitting H&Ps, discharge summaries, op notes. All of those are coming through these point-to-point interfaces, loading directly into my EHR. So I don't have to go look somewhere else to find these things, to find out what happened in the emergency room, to find out what happened in the hospital. On top of that, we have set up event notification services in Central Mass. Part of that is through Safe Health, which was one of the grants that you heard about that we implemented. Event notification service, so that we're notified whenever one of our patients show up in the emergency room, and not only do I get an in-basket message instantly saying, so-and-so just walked into the UMass emergency room, I'm also, our EHR automatically sends them back through the Mass Highway as a direct message, a summary of the patient's problems, meds, allergies. The problems give all the description about the history of that problem and the care plan for that problem. And that's all immediately loaded back into their system. Automatic, no one does anything. So wherever the patient's getting care, they know about it. In fact, we use that same event notification system to notify Home Health Agency that, hey, this patient that you've been following of ours, they just showed up in the emergency room. In fact, they were just admitted to the hospital. Don't bother going to their house today because they're not going to be there. Or they were admitted to they weren't admitted, they were sent home. Make sure you go to their house tomorrow because they need to be seen for follow-up. Only 10% of the time did home health agencies know patients were going to the emergency room. Now they know all the time. We also are integrated with the payers. So we take claims data, because we're at risk for so many patients, we get access to the claims data. We don't just put it in our data warehouse. We load it right back into our electronic health record. So I know about the care that patients have received at other places that we're not directly interfaced to, all around the country. And for instance, for Fallon, we're not loading data monthly, we're actually loading it weekly. into our EHR so that we have it almost a much more timely basis. We're connected to the state, the public health agencies, registries. We also load data for all of our encounters to the Massey Health Collaborative, where they have a specialized registry, and we do benchmarking with other organizations there. And we do have our patients connected. About 40% of our patients are active online portal users. We have much more than that signed up, but some of them, realistically don't use it. So we're connected. Wherever patients are, people know about them. Now, the in-basket is one of the biggest areas of complaint from physicians, and we've spent a lot of time working on improving the in-basket so that it's not as onerous. So for instance, we set up guidelines with our staff. And so they can't, when I've got a nurse on the phone talking to one of my patients about strep throat or a tick bite or poison ivy, that they have guidelines that they can execute without even telling me, that they know they can actually give advice and treat some of these things because we've set up guidelines, and so that things can happen quickly. And those are baked into our electronic health records, so they don't have to remember these or have to have a cheat sheet. It's integrated into our system. We've also done some physical redesigns so that I'm physically co-located with, my nurse, my medical assistant, my secretary, so that I can hear them talking to patients over the phone. And I've learned that my nurse is pretty damn smart, and she's given really good advice. And so I've built up a lot of trust in her. And that trust is important because, I've conveyed, I trust what you're doing a great job, so they don't feel the need to CC me on everything that they do because they know I trust what they're doing. And also when I ask them to do something, I know they're going to do it. They don't have to say, hey, I did the thing you told me to do. That's just one less message I don't really need to see. So that building that trust within our team has really been helpful as well. We also have, for the in-basket of test results, if anyone of you have looked in the lab results that come back from Quest or LabCorp or whoever, half the tests are marked as abnormal. And they're not, sure, they're abnormal technically, but they're not really that important. And so what we've done is we've used decision support within our EHR to flag the things that are truly significantly abnormal. These are critical. These are significant changes. These are things you have to pay attention to. And that helps us integrate with guidelines we've given to our staff about which patients they can just automatically tell that their results were normal versus things I need to take care of right away. And that also helps reduce the in-basket volume and help triage these. We also, for medication renewals, we do a lot of medication renewals. We've got it set up so that a medical assistant, says, okay, we're going to be renewing this medicine, and all of the relevant information about, when was the last visit, when's the next visit, what are the monitoring test results that are appropriate for that, and when were they last done, and are there orders in place for the next one? It actually tells the medical assistant how many refills to authorize based on all of this information for each specific medication, so that the MA just enters the medication, pens it, sends it to me, and I've got everything I need to go one click, signed, yes, or one click, don't do this, let's see the patient. So it makes it very efficient for everybody. Consult notes. This used to be a big source of problems in our in-basket. Every single visit to the, podiatrist for their toenail trimming or for their eye doctors to getting their exams, everything came to my in-basket. I don't need to see most of those. So we've set it up where we automatically route important ones to me, and I don't see the others. They're in my EHR. I'll see them the next time I see the patient, but they don't need to be in my in-basket. And so that's also reduced the volume with that automated routing. And then the last thing is that we get, because we do have all sorts of stuff coming from the hospitals, most of that files silently into my EHR. It used to be faxes that would come to us and I'd have to see everything. No, our EHR triages what's important and also who should see what. So that ER visit, it actually goes to my nurse. My nurse gets it and says, let's see, is any follow-up necessary? And does the doctor really even, care about this, that they inappropriately went to the ER for a sore throat? The nurse tells the patient that they shouldn't do that. So again, we've made a lot of triaging automated into the EHR, and as a result, we've cut in-basket message volume by 25% as a result of this, and it's been sustainable. Also, we want to make it easy for the right person to do the right thing. So, the system, when any of us are seeing a patient or talking to them on the phone, the system's looking at, how old is this patient, what's their sex, what's their insurance, what are their diagnoses, what meds are they on, what tests have they had done, what tests have been ordered, and it tells you, because of all of these factors, this patient needs to have these tests ordered, or these, and here's the order, oh, by the way, one click so you can just sign it, or it'll tell you, wait, this lab order's already been ordered. Please remind the patient to go to the lab and get them done. It just makes it so simple to do the right thing. We have radiology orders where we call them one-click orders, where 80% of the time, people are ordering CAT scans or X-rays or whatever for specific problems. So we say, for if you've got back pain, because you had an injury, this is what you want to do. If you've had, if you think they've got kidney stones, this is the one you want to do. And we've reduced, we make it very easy to order the right test. And we've reduced the number of imaging orders that had to be changed because they were ordered incorrectly by 80%. So improve the efficiency in ordering. When alerts for following up, when patients are in the emergency room or in the hospital, well, actually when they've been hospitalized, the system waits 3 days, makes sure that there's been some follow-up appointment scheduled, and if not, it doesn't send me a message saying, hey, this patient needs a follow-up. It sends my appointment secretary saying, hey, this patient needs a follow-up, just go ahead and book it. Again, the right person, making it easy for them to do the right thing. We've got alerts to our anticoagulation clinic. If I write a prescription, an antibiotic, it automatically tells the anticoagulation folks to make sure there's a follow-up done. Automatically, I didn't need to do anything. We've got lung nodule and incidental finding tracking that works very efficiently. The radiologist, we made it easy for them to report an incidental finding to me. We basically gave them a paragraph. You just, they've got this speech recognition where they say macro number 1, incidental finding, and it automatically sticks a paragraph into their note, so it's easy for them to do. And it also sticks a little code, so when it comes into my EHR, whether it's my radiologist or the hospital's radiologist, the EHR flags it and says, whoa, there's some incidental finding that needs to be followed up, automatically puts that patient on a registry for people to track, make sure that they don't get lost to follow-up, automatically flags it in my record, my in-basket, saying, paying attention to this, there's something wrong with this, don't just ignore it. And that happens even if they're in the hospital or the ER. That comes to my in-basket. All this automation makes it easy for us to do the right thing. Now, documentation, that's one of the things we spend a lot of time doing, and the documentation is burdensome. And part of that is because of regulations and some of it is payers' expectations. So who do you want to make the note? Should I be doing everything? Well, so here's our order of preference for who should be making the note. So first of all, the computer should be making the note. Let the computer do the writing if it's possible. They've got histories and med lists and allergies. All that stuff automatically is part of my note. No one actually has to do anything to make that happen there. Test results should automatically be able to populate for specific problems, which they do. And the fact is, my last note is a great source of information. And we have a standard workflow when I'm seeing a patient for a physical that my medical assistant is automatically copying my last physical exam, the exam part, into my current note. Now, there's a lot of controversy about this, copying and pasting. Well, the fact is, that patient of mine that had an amputation of their leg, that has a thyroid nodule, that has a skin lesion, that automatically appears in my note. So I make sure that I'm checking that today and that they don't accidentally grow that leg back because I forgot to remove that in my note. So it actually allows us to give safer, higher quality care. And by the way, it saves me a ton of time in my documentation. I just update things. The patient, they're a great source. No offense, we're all patients, but if they could do work for me, that's great. So they're at home, through the portal, or when they come in for the visit, they're given a tablet, and they can fill out, update, what their family history is or their review of systems. That's all done in advance of the visit and becomes part of my note automatically. Now, a nurse is the next person who I like to write my note. When they're triaging the patient over the phone about their problem, they're going through all of this, writing all this history of the present illness. It's great that they're doing that because we're getting history and we're not tying up an exam room. So that's actually very cost effective. And then I just copy what they wrote and stick it in my note, and now I own it. And that's certainly very efficient. Now, when the medical assistant puts the patient in the room, they're also a good source of putting information in. They actually are checking and confirming what medications the patient is on, any new family history, how's your smoking status. All of that stuff is being entered by the medical assistant. So the fact is, by the time I get into the room, most of my note is actually already written. So yeah, so then I come in and I do some stuff, and speech recognition is wonderful. We use that for some of the history of present illness. We use that for some of the medical decision making at the end. Again, a very efficient tool. Then the next is, we actually no longer have this, but we had people actually dictating and having transcriptionists typing that. That would probably be the next most cost-effective thing. We don't have that anymore. Doctors typing, some of us type better than others, and we still have to do that, but that's really low priority. We don't want us to be doing a lot of typing. And then probably the last thing is the scribe. I know scribes are starting to become more popular. There's actually an interesting study in JAMIA, I think it was last year, where they showed that scribes actually didn't reduce the incidence, was not associated with the reduced incidence of physician burnout. Now, it wasn't truly looking at cause and effect, so we can't say for certain whether it's just if you were going to burn out, it's not going to make a difference whether you have a scribe or not, or the people who got scribes were more likely to be burning out. But it wasn't a clear correlation. But they're expensive. We use them, for instance, in our ophthalmology practice. I'd like our dermatologists to use them as well, but haven't convinced them yet. So there are places where they're very cost effective. So that's really the order which we have documentation done. Now, this is, I think, one of the most important things that we do, and it's led to all the other things that we do, is that you need to have clinicians involved in the implementation and optimization team. We've got 4 practicing physicians. We each practice between 20 and 60% of our time seeing patients, so we're using the actual tool, the EHR, that we're asking our colleagues to do. I learned this quote from Dr. Sands, who you'll hear later, that you have to eat your own dog food that you feed to your colleagues, and that's what I do. And it really is important that, because now we identify right off the bat when there are problems, or we understand the problem that our colleague is talking to us about. We also have a physician assistant, we have a medical assistant. In fact, our EHR team is run by a nurse. We took one of our urgent care nurses, we taught her about electronic health records, and now she's our boss. So it really is very important. And definitely, you need doctors and nurses, because we have different brains and they work well together. Very important. We also have made most of us certified analysts. We've all done the actual training. I've got a little certificate on my wall signed by the CEO of Epic saying that I'm a certified analyst. And that's important because we know how that system can work, and that when we see a problem, we actually all work together and solve those problems in the most clinically appropriate and efficient way. 2 of us are actually Cache, which is HIMSS programmers. Thank you, folks over at Image Systems over there. Great job. So we actually are developers, and our EHR gives us the source code for free. They give us an integrated development environment to do the programming for free, and it allows us to enhance our system. And that's also really important because we've got about 100 routines that just tweak little things that that save us clicks. And it really all adds up to make a big difference. Last thing that we've done is we've extended our reach of clinicians. So we've created clinical super users, physicians, advanced practitioners, nurses, medical assistants. We have a couple hundred of these super users throughout our organization that help spread the word. We give them extra training. They're out there as the first line of defense when people are having problems. And they're also a great source of ideas and feedback. Right now we're planning an upgrade in September, and they're spending a lot of time going through the system, checking and talking and looking at configuration that we ought to be doing. So it's really a great way to extend our reach. Now, and we've made it easy for people to give us ideas. They know how to email us, to call us, to grab me when I'm seeing patients or my colleagues, to make sure that their feedback, their problems are presented to us. And we're very quick at fixing these. If there's an issue, or a great idea, we've implemented them the same day. We've just had some simple changes. Hey, it'd be great if this piece of information was right here when I'm doing the work. We just add it in and it's done. Sometimes the things are done on a weekly basis, sometimes they're done on monthly basis. But regularly updates builds that trust with our users. And the other thing is that we do have occasionally some really tough decisions to make, and that's why we do have a governance committee that only meets a few times a year for those really tough decisions, but it's got doctors and nurses and everybody from different sites and different specialties. We all get together. Otherwise, outside of that, the clinicians on our team in the IT department, in my cubicle next to the programmers, we are delegated to make the decisions on a day-to-day basis and make the changes, and that's important. We've been trusted to do this, and we've shown that we deserve that trust. So does it make a difference? So we have done Press Ganey surveys, and we rank in the top 3% in the country for physician acceptance of our electronic health record. So. Thank you. So it makes a difference. And so we also, just so we can brag, we are in the top 10% of the country for 90% of HEDIS measures, HEDIS quality measures. And we also, if you take a look, this is us over here. This is the total cost of care that you heard about in Massachusetts. We have the lowest total cost of care as of 2018 per the Massachusetts Health Policy Commission. So not only are we keeping our physicians happier and our staff happier, we're also providing higher quality, lower cost care. So how can everyone else be like Reliant? Well, I think of this like two different groups. There are large organizations and there are small practices. So the large organizations have to have certain things in order to make it work. So let's see. Well, do they have good EHRs that are highly configurable? Well, the answer is yeah. I mean, every large organization, they've got a good real EHR, and certainly the EHRs are very configurable. Can they have dedicated clinicians? I mean, our ratio is about 1 FTE of a clinician per 100 providers. And I think that's a really good ratio to have. And these have to be practicing clinicians, as we talked about. If they're just people who aren't practicing, you're not going to get the same value out of them in terms of trust and in terms of understanding of what the issues are. And sure, every large organization could pay for clinicians to be on the team and train them appropriately. Let's see, can they delegate decision-making, so it doesn't have to go to department chairs, but can actually be dedicated to this team of clinicians, these practicing clinicians? Yeah, they could do that. They just have to, delegate and trust them. And can they earn the trust of the physicians, that they're representing? Sure, they should be able to do that. It's just a matter of putting, the proper training, giving them the time to actually accomplish that work, and staffing it appropriately. So large organizations have no excuse for being just like Reliant. Now, that may be different for smaller practices. The smaller practices, okay, do they have good EHRs? Yeah, actually there are a lot of good EHRs out there that are highly configurable and can do most of the things that I just showed you. So yeah, that should be possible. How about staffing? No, you can't do, let's say, if I've got 100 physicians, I need 1 full-time clinician who's going to be trained and dedicated to this, and that's great. If you've got 10 physicians in your practice, you can't really have a 0.1 FTE. You can't have some doctor working 4 hours a week and expect them to do a good job. They can't be trained. They can't, they don't have the time to get all the training, to pay attention to all the problems, to figure out how to configure and fix things, to actually do the configurations themselves, to make this actually work. That 4 hours is going to disappear. I mean, because we're going to be taking care of patients. So that's not going to work. So how do we, and so we'd say, well, how do you what's the alternative? Well, they've got vendors, they've got EHR vendors who are, doing the implementation for them. Shouldn't they be the ones that are doing this? But they don't have enough clinicians on their teams either. And they're not necessarily aligned with their incentives. I mean, their job is to get it plugged in, meet meaningful use. All right, we're done. And it's not the same. Meeting meaningful use is not the same as making your system hum and efficient so that you can be good, efficient clinicians and happy. So what do we do to support small practices? You know, you need clinicians involved just like we do in the larger practices. Now, in 2009, they actually set up regional extension centers around the country. Massachusetts had a regional extension center. And they created these implementation and optimization organizations. They were funded through federal grants to actually help electronic health records get implemented in a small practice. But that's the operative word. It was to get them implemented and to meet meaningful use. It was not to optimize them to the level that we need. And so we need to change the way we're looking at this to really focus not on just meeting meaningful use. We need to focus on physician satisfaction, nurse satisfaction, medical assistant, secretary, therapist satisfaction, patient satisfaction, and whether we're meeting those goals in terms of efficiency. And satisfaction. So the vendors can do that optimization, but they need to be properly incentivized financially. They need to be staffed with the clinicians at the right ratios to make that possible. There need to be more consultants to do this kind of work, to bring everybody up to that higher level beyond meaningful use. And maybe there needs to be public funding, whether it's federal or state, to help with this burnout crisis, because it is such an expensive and costly in so many ways for the lives of our patients and our clinicians, that maybe there is, we're funding the opioid crisis, maybe we need to be funding this physician burnout crisis. So I'm going to hand this back to Dr. Chaoui to talk about how people can be better than Reliant, so that we're not number one. There you go.
You can stay because we're okay. So, as you can see, leadership matters, and it's very important. With leadership, you can make a difference. Dr. Garber is talking about larger practices. I have a smaller practice. I'm one of those dinosaurs where I am a solo physician in a practice. So, you have your homework now. You know where to put your energy with smaller practices, because I believe that, I would love to have access to the same facilities that it would make my patient care more efficient. So I just wanted to say part of our paper is to fix the whole system. It's not all about EHR, so do not feel like we're just focusing on you. But there are lots of other people or stakeholders that we are talking with to actually help improve the system for our patients. The health plans, the insurers, to help us streamline the administrative trivia that has nothing to do with patient care, like the prior authorizations, the checking the boxes of quality measures. The state and federal agencies, not to take our notes as a bill. We don't want to write 25 pages in order to be able to bill. We want to actually put pertinent information that actually has something to do with patient care. Medical school and residency program, to pay attention to our students and residents and have them spend more time with patients, give them access to counseling and support even after hours, because they're busy and then they say, I want to talk to someone. Well, it's after 5 o'clock or 6 o'clock, there's no one there. EHR vendors, we talk about this. Hospital and health big systems to help us with the chief wellness officers, where you can go to someone and not feel like if you are going to talk to someone, you're going to be penalized. And then lastly, the Federation of State Medical Board is talking to the Board of Registration of Medicine saying, when you make it too restricted, physicians don't come forward if they have a problem. So please make it easier for physicians to actually take care of their health as well. So EHRs are here to stay, and I love it. But that's what I want to see in the future. And now, and you probably will see this at Dr. Garber's office, where the physician is happy, the patient is happy, and then we still have the electronic record between them, so we can collaborate together and we can make this change, and we can make it quickly. So I want to thank you, and I want to tell you that please help us bring back the joy into the practice of medicine and help preserve the patient-physician relationship. And I would like our patients to understand what's going on, and help us advocate for the better healthcare for the future. And thank you. So,
I guess we can take questions.
Well, it not sound like that. It's basically the presentation sounds like we put a big goat in my house, which makes everything much more frustrating. And now we're trying to take the goat out and makes us happy, but that partially only solve the problem of a physician burnout, because you eliminate some of the requirements, but you still the EMR causes us to be overseeing too many patients, too many responsibilities, too many overseeing, and really taking the fun of medicine, as Dr. Chaoui said. Okay? Do you understand what I'm saying?
yes.
Yeah,
So,
we put a big goat in my house. We're just taking some of it out, cleaning it up a little bit, but I still have the problem, and the problem is the expectations, the frustration that we have with managing so many people, overseeing things, not have the personal connection, taking the joy out of medicine.
so thank you for this question. I will say that I have not, during my endeavors talking about this crisis, I have talked to a ton of physicians. I have not had one physician complain of taking care of too many patients. Physicians love to take care of patients. Part of the joy of practicing medicine is to take care of patients. So that is the thing that actually brings us joy and happiness. The part that frustrates physicians, and you called it a goat, I call it the AHR. And I think the AHR is like a drill. You don't actually, when you want to use a drill, you actually use the drill, it works for you. The AHR does not feel like a drill to me in order to do something. It feels like a cumbersome thing that is actually not getting the purpose done. So what I would like is, yes, I'm happy that now we have the AHR. We have a lot of reasons to have the AHR, but now we need to focus and we need to work together to make that EHR actually work for patients and physicians. And I believe with the leadership like Dr. Garber and the science and the technology that you have, that you possess, if you put doctors and your IT knowledge together, we will accomplish this.
And I'll add also what you talked about, reducing the regulatory burdens and the payer burdens is also helpful. And then the other thing that Dr. Parker had talked about in the beginning was that having a team-based care, so that I'm not responsible for managing all the social determinants of health. We own pharmacists, we own care managers, and they're very helpful as nutritionists and other educators as part of my team to work with me, and so that we can provide the kind of care we want to give and manage the population of patients that I want to take care of.
Hi, my name is Melissa Mio, and I am a past president of New England HIMSS and on the board, so thank you both for speaking. It's very inspiring to hear you leading the way in Massachusetts for all of us patients, because we're all patients, right? So my question for you, Dr. Garber, is I was driving around with my 10 and 9-year-old, and I may have imagined this, but I heard an ad from Reliant Group medical group saying 1 million patients. We're looking for 1 million patients, 1 million records. Could you elaborate on that and tell us about this? Because I found it interesting, but I couldn't listen because of the chatter of my 2 children. So thank you.
Sure. So this actually has to do with precision medicine. So there's a national project being done by the National Institutes of Health. And it's what they're striving to do, not just at Reliant, but across the country, is to get 1 million patients to participate in this study, to create a giant database, a secure database of genomic data, of electronic health record data, of environmental exposures, lifestyle information on 1 million patients, so that researchers can do thousands and thousands of studies on this database to make it easier to identify diseases, to be more proactive in preventing diseases or finding better treatments for diseases. So it's really part of the precision medicine initiative. There's a New England consortium, which is partners and Boston Medical Center and Boston University or Tufts. I forgot who the third person is as part of that consortium. And so on NPR, you'll hear those ads as well. So there are a few different ads, and we basically are the recruitment sites through the Partners Network and Reliant Network to sign up for that. And this is the All of Us research program. Yes. If you go to joinallofus.org, you can learn more about that and how you can sign up.
I'm Joe Heyman from the Mass Medical Society. Before Meaningful Use, I was in solo practice and had a fabulous EMR. And then Meaningful Use came along, and my EMR got progressively more difficult to use. And the major reason was because I started to have to put in extra clicks for third parties' needs rather than for my needs. And, some of those third parties are people like Acadia, and some of those third parties are insurance companies, and some of those third parties are the government. So how do you get rid of all those extra clicks?
Well, first of all, I'll talk about the clicks specifically. Assuming that there are no changes in the rules, you basically have somebody else do the clicks, or we've configured our EHR to record the information as a byproduct of the work that we're doing. So that helped to the extent that it was possible.
But also, Joe, I think changing the rules and paying attention to the patient, not to the clicks, is very important. And I do believe that people are hearing us now. People heard us. CMS heard us. They are working on getting rid of the long note and the note as a essentially bill, making it. They're changing the codes. Before you had to bill a certain 992, 1, 2, 3, 4, 5, and every note has a certain amount of information in it. They're going to try and change this and make it into 1 or 2 codes, and then you just write a real note. So I think changing the system, changing the requirement from the government and the state, and focusing on the patient back again, I think we all have to work on that.
A question from the back, thank you.
Thank you. This is a question for Dr. Chaoui. I'm from industry. So you give a very impressive speech, especially the picture that shows the past and then how doctor practice really impressed me. So my understanding that the current EHR or EMR, so we all know that we cannot go back to the old age, which without the EHR, EMR, because our organization needed. So looking at your presentation, my understanding that really the interface between the EHR and the doctor need to be improved. So I would like to know that from your practice experience, whether you think innovative hardware and needed from your side so that it improve that interface, filling that gap. So this is basically the question. I'm from Inc. My table is here. So meanwhile, I would like to invite you and other medical doctors during the break, stop our tables to see our new technology product really can help you to improve that practice experience, restore your old practice experience, meanwhile still can benefit the EHR for your organization. And then find out whether we can help over there, try to close or at least improve that gap. Thank you.
So I think you're asking me my dream question. So my dream question, essentially, if I have to summarize what you asked, is what is really my dream interface so we can practice medicine the way we're supposed to practice medicine? Is this summary, good summary? So that's a fantastic question, and I thank you for it. And I will say that if I have to, go and think about how would I like to practice medicine, I would like to continue to have the EHR. I would like to continue to have the data in order for me to actually deliver better care. But I would like to spend my time looking at the patient, examining the patient, listening to the patient. So I would like to be in a room with the patient, looking at the patient, asking the patients all those questions, examining the patient, and telling the patient.
But no rectal exam in front of all these people, okay?
No.
I just,
But I would like to tell the patient, if you need a CAT scan, if you need labs, if you need anything, I want to tell you exactly what I used to tell you in the past and be able to leave the room, go to the next patient, and then whatever I talked about gets to be done for the patient. Now, if I order an MRI, if I ordered anything, I have to spend an extra time not only to order the MRI, but after I order the MRI and the patient is already at home, I have to be on the phone begging for the insurance company to cover that MRI. So in order for me to practice good medicine, I only want to actually take care of patients. I want to use my art and science for caring of the patients. And I would like you to please create a system where doctors don't have to do anything that has nothing to do with only patients. That's it.
and I'll add to that. So when we're having our visit, now I'm the doctor, and we actually have set up our monitor so that it's over here. So we have a triangle between us, and we actually have put 32-inch monitors in our exam room. So, I mean, part of that is because my eyes are getting older, but part of that is so that it becomes a tool, it's an asset to our conversation. And so that's been helpful. And then the other thing that you may want to keep an eye on what Nuance is working on. They actually are working on this ambient speech recognition and natural language processing so that your dream about saying, EHR, order that MRI for back pain, and it does it. So, and it documents our notes based on the conversation. Right. So that people are working on that. All of you keep trying to solve that problem. I think we're out of time. Or do we have time for any more? Okay.
I'm Jay Spitolnik. I direct the Health Informatics Master's Program at Northeastern. You talked about the differences between large and small practices related to the EHRs. Are there any other demographic differences that have an effect on the burnout? I think, just for example, the younger people coming out of school today as doctors, PAs, nurses, whatever, were born with laptops and smartphones in their hands, but then you've got the older physicians who don't have the same level of familiarity. So are there demographic differences that we can look at as well related to the EHRs that affect the burnout?
So one of my, when you heard that one of my favorite things to do is to teach. So I have all those young, amazing, generation that love computers. And they type so fast you can even see their fingers. So, but they are very frustrated because they feel that their new job is typing into the CMR.
Of course, they only do it with their thumbs, right?
So that's the truth. So I have these students that sit on the computer and they're very fast on the computer, but they don't look at the patients anymore. And I say, we need the new generation. So if you're creating a generation of fast users, you succeeded, because the new generation will do the job a lot faster than I would. But I don't think this is what you are looking for. You are looking for someone to actually go back and take care of you and listen to everything you say, because there are lots of nuances. Every time you're in an exam room, every word counts and every single thing, every body language counts. And I feel like we are losing this, and I would beg you to please bring this back to us.